here. Dr. Wood is a giant in reconstructive urology. She is the person who's brought the idea of transitional urology to the forefront. Now programs across the country have transitional urology programs because of Dr. Wood. And we're incredibly grateful for her visit, and we thank her.
Thank you, Ben. All right, without further ado. So I'm going to start with a case. Can you still hear me if I step aside, Marshall?
Yes, sounds
Okay,
good.
perfect.
Sounds good.
Okay. So this is a consult I got about a year and a half ago for a patient who was 34 in the NICU for a suprapubic tube. And, you know, like we usually do before we go over there, we pull up the film. And this is the CT scan, a couple of slices. What you can see here is he's got bowel right underneath his skin. And in fact, you could, on exam, you could see bowel undulating underneath his skin with a massive hernia. He's got a pelvic malrotated kidney with a little bit of hydro. And most importantly, he's got this indwelling Foley catheter with a massive decubitus ulcer, which is the reason for the consultation. And what I came to learn is that this patient had been admitted basically on and off to our hospital for over 18 months. Initially with Ogilvie syndrome requiring exploratory laparotomy, and then had an incarcerated hernia requiring resection of a large amount of bowel, and then now short gut syndrome on TPN. Just sort of everything you can imagine went wrong, including the fact that he hadn't been maintained with an indwelling Foley that whole duration. No one ever consulted urology for this guy. And so we get a cystogram, and what you can see here is he's got this very small bladder, almost no capacity, an open bladder neck and posterior urethra, and a fistula that's draining out through where his Foley catheter has eroded through into his perineal incision. So what are the chances that a suprapubic tube is going to be feasible or help divert this guy's urine? Zero, actually less than zero. So we're going to talk a little bit about, first I want to just start talking a little bit about the natural history of aging in spina bifida patients. Then we'll talk about some of these things, which I think are really important things that happen to these patients in adult life that we might be able to head off or help manage preventively as they age. So when I started in residency, and also Dr. Breyer, because we're the same year, 2000, what is it, 2003? Yeah. I was sort of taught like, oh, okay, spina bifida, they're in these clinics, these pediatric clinics, they're multidisciplinary because they're changing, and you got urodynamics all the time on that, and their bladders are changing. But then they hit adulthood and they're good. Wrong, totally wrong. So what we know is that indeed in spina bifida and in all human beings, the bladder and bowel function is changing and patients are growing in pediatric life. But in adulthood, as we know for all humans, there's declining function. Now, the major difference between an unaffected individual and a spina bifida affected individual is that when unaffected individuals get into, past puberty, right? There's a long duration where continence, bowel function, cognitive function, motor skills are pretty stable. And then you see a decline starting in the 8th, 9th decades of life, 7th, 8th, 9th decades of life. In spina bifida, that decline starts probably in early to mid-adolescence, and it continues. So they never really plateau like we see with, and this is actually a problem, even in the spina bifida community. I'm part of a consortium of organizations, so is San Francisco, called the NSBPR. It's a CDC registry where we enroll patients who are in our multidisciplinary clinics, and we collect data on them. Even the NSBPR insists that it's a failure if the patient has recurrent incontinence after they've achieved continence. And that is an expected outcome for these individuals. And so just to prove that to you, this is community data in an Australian population looking at incontinence by sex through the ages. And you can see patients or humans in their 40s, we see incontinence rates somewhere in the 3 to 8% range, right? It's urge-related incontinence. But you see up into the, into the 8th decade of life, we're seeing rates in 30, 40% range. Same thing with fecal incontinence. The prevalence of fecal incontinence is somewhere around 8%. This is actually a meta-analysis that sort of summarized all this, but you can see that there's a clear linear effect with age. Young people, the rates are pretty stable at around 6%. But you go up into the 90s, and about 1 in 5 patients are experiencing fecal incontinence. What else happens with aging? Well, mobility declines, we know that. Memory and cognition change. Quality of life changes, that's health-related quality of life, and also psychosocial quality of life. And patients lose functional independence. And my argument is that this happens much younger in spina bifida affected individuals. So this is data that looked at gross motor function, social communication skills, and then both personal community integration skills in a spina bifida affected. I don't think I have. Well, I can use that scan it. In a spina bifida affected population, and then a case controlled population, you can see, and this is a mean age of 34. So these are adults, but they're not, geriatric adults. These are probably the mean age of the people in this room, if we exclude Dr. Goldstone and Dr. McInnes. Median age. Okay. And then the second list here, we can see our looking at. So this is actually was a study of what I sort of think of as geriatric spina bifida patients. These are patients that are over the age of 50. Okay, which is not what most people think of as a geriatric population, but in fact, they're my oldest patient of all of the spina bifida patients in my practice is 68. So 50s and 60s is pretty geriatric. And most of the patients in that population who live into their 50s and 60s tend to be lower level spina bifida who were ambulatory in their younger lives. But you can see here, this is self-reported loss of ambulation. Most of them lost ambulation ability by their 40s, okay? And you can see the decline clearly through the decades going up to age 50. This is a Norwegian population. And this is data out of the NSBPR. We just had a large pilot collecting health-related quality of life on these individuals in pediatric, adolescent, and adult patients. And so these are patients that were just enrolled in select voluntary departments who were participating in the NSBPR. So this data is unpublished. It will be presented at the World Congress next spring. And what you can see here, so this is sort of looking at time through, I think we defined children up to age 12, adolescents 12 to, it was either 22 or 24, and then adults after that. And the mean age of the adults was still quite young, 32 years old. This is still a pretty young population. And what you see here is that the pediatric and adolescents, their pain scores actually probably improved with time. But you can see their major increase in pain scores with aging in the adult population. And if you compare that to self-reported quality of life over here, this translated directly into self-reported quality of life, where we see overrepresentation of adult patients who rated their quality of life as fair or poor relative to their pediatric and adolescent partners. This is data from an old study that came out of NSBPR before we really had a lot of adults in this population. So this just looked up to age 22. And what you see here is, what do you expect? I mean, people, I guess in my mind, I always thought, well, yeah, patients with spina bifida become increasingly continent through childhood. What we see is increasing incontinence starting in adolescence, which won't come as a surprise to Dr. Hampson or Dr. Breyer, right? These patients, once they get into adolescence, oftentimes have a substantial decline in their urinary function and continence levels. And also loss of ambulatory ability, community ambulation here, and not surprising, an increase in pressure ulcers. And these are young people. These are kids that are probably still living at home. And so this is a picture of that patient that I saw when I got called to the bedside. I wish I could say that this was like the worst thing I've ever seen, but it's not. This happens in my hospital and in hospitals across America to these patients every single day. This patient ultimately died of a combination of malnutrition and his wounds and pulmonary failure. And it was something that, like, in my mind, had somebody been there at the beginning of this sort of downward spiral of his life to say, hey, let's get urology involved. One of these 5 XLAPs that he's in, why don't we take his bladder out and do something about it? You know, I mean, there was just so many opportunities to potentially head this off. But to me, this is like, Civil War era way to die. So I'm going to first talk about ulcers, because I think it's the biggest problem in this population. When we look at ulceration, The biggest drivers, this is again also from this NSBPR registry, looking at risk factors that drive it. And on the left here, you see a multivariate analysis. It's age and the level of lesion. Level of lesion being a direct surrogate to whether that patient's in a chair or not, right? Because the higher the level of lesion, the more likely they are to be non-ambulating. And also with age, the older they are, the more likely they are to be non-ambulating. And probably incontinent as well. And when we look at prevalence, we see about 1/4 of these patients have had a pressure ulcer in life. These are from an older population in this subset. And most importantly, almost 20% of them have had an ulcer within the past year. So I think if we think about anything that happens in medicine at a rate of 20% per year, we have to call that an epidemic. It is an epidemic for this population, and it's one that there's very little attention paid to. We don't really even understand great ways to prevent these. So like everybody sitting out here or on Zoom saying, well, I'm just a urologist, what can I do about this? Well, there are a lot of things we do to our patients that promote ulcerations. Obviously, patients in a tough spot and they need a catheter, you put a catheter in them. But you can't just put a catheter in them and just let them go and not have a plan to get that catheter out. And every week, again, I'm sure Dr. Hanson's the same way. You see patients coming in, they've had catheter in for 3, 4, 10 years, okay? That is not a sustainable solution for these patients, and you always have to have a plan to get that catheter out after they get through their acute issue. Medications are a big thing. As these patients get older, they get hypertension, they get put on hydrochlorothiazide, they get diabetes, they get put on all sorts of SGLT2 inhibitors and types of things that are going to make them more incontinent, more instability to their bladder. Indifference, again, like the only way I can explain what happens to these patients who come into our hospitals is just nobody cares to think about, like, maybe we should get other people involved or have this patient helped out in some way. And institutionalization, they just go from rehab to nursing home to hospital, and there's nobody really sort of thinking about the long-term plans. Prevention is really the major strategy for this, because once these patients get these wounds, they can be almost impossible to fix. We've talked about avoiding an indwelling catheter, thinking about diverting them before things get really bad. And most importantly, I've really learned a lot and benefited probably more than I've gotten given back to my partners in physical medicine and rehab. They are incredible at their work, and many patients who are in pediatric spina bifida clinics have PM&R built into the system, and then they get into adult life and they lose track of PM&R. And so bringing them back in and reconnecting them with that, because they're just going to their wheelchair companies to get their wheelchairs up. But these men and women, they understand what happens when they gain weight and changing their wheelchairs. They can help them navigate. They have resources to help them navigate the quagmire bureaucracy, getting new DME, which is a huge problem for these patients. Making sure their ROHO cushion works and it's not deflated, making sure it's replaced. And then thinking about home equipment and supplies and what's happening at home. I had a very famous patient that had a bad ulcer problem that I managed with the plastic surgeon that we did a lot of work with. And we were like, what is going on? Why is this thing getting worse? We're doing everything we can. And then we finally said, well, what's happening at home? And he lived in the basement of his mother's house, and to get down to the basement, he'd have to scoot on his butt. So, I mean, you're never going to heal a wound if that's what's happening at home. So you got to have people that are thinking holistically about what's happening, not just in the hospital, what's happening at home. The mainstay of management of these, when they do happen, is divert the urine and fecal streams. It's not rocket science, but sometimes an SB tube is not sufficient, particularly if there's a lot of sediment in there, or the patient has a very small, unstable bladder, open bladder neck. And so sometimes it's reasonable, but in a patient where you have a cystogram like the one I showed you, that's never going to work for that individual. Team approach is really important. And as I referenced earlier, I had a great plastic surgeon. She just left to go to the VA, but she was really the heart of our wound care team, and had built a lot of camaraderie in the team with our orthopedic partners, our colorectal partners, so that we just passed the baton. So, the first exam was always sort of coordinated by her, unless the patient was in my clinic with the Hoyer, and I would call her, she'd come up, we'd video into our orthopedic partner if we needed to, if he was in the operating room. And so that's really important. And then some of these things in the hospital, making sure they're offloaded, they're on an appropriate bed, they're limiting their sitting. You got nurses looking at their backside, changing their wounds 2 or 3 times a day. And then again, involvement in case management and social work to talk about what's happening at home, what they need at home to be successful. We always manage these as a staged approach with an exam, oftentimes an exam under anesthesia, sometimes at the bedside, debridement of the wound acutely and diversion often simultaneously, muscular injury position, and then skin coverage sometimes if appropriate. This is a classic bedside. I mean, I have a million of these on my phone because we did a lot of these. We do a lot of these together, but this classic bedside exam, we usually measure these defects. And then, this is a patient that urology was consulted, and the resident went by and said, "Looks fine to me." And Christy Cavalier called me. She said, I think we need to take a look at this guy together. And so, because I think there's like fluid coming out from under there. It seems a little fishy to me. So, we roll this guy over and we look in here, and indeed it looks like there's some fluid. And then I stick my finger in here. I don't know if you guys can see this here, but there's something sort of bluish, and indeed there's a Foley catheter right there. So they can be hard to see, but you can definitely feel them. So if you're called to the bedside to do an exam under anesthesia, put your finger in that wound. Feel for a catheter, feel for the urethra. This is a lady, you can see she's had a girdle stone procedure over here. She had necrotizing fasciitis, had lots of problems. But she kept like getting this little abscess thing up here. And then I explore it, and I couldn't find anything. I'm like, what is going on here? This is a mucus fistula here. So sometimes a cystogram can be helpful for that purpose. Also, this is for cystogram. You can see this tiny little fistula. Sort of lost my pointer here. This tiny little fistula coming out from the bladder neck. So cystoscopy can be helpful. It's often easy, especially if you're doing an exam under anesthesia. It's easier to do a cysto sometimes than to do a cystogram in the operating room, depending on how the patient's positioned. But a cystogram can be helpful, and sometimes more helpful if you can't find anything. And then we always use MRIs in specific situations. If there's a concern for osteomyelitis, we almost always get an MRI and an inflammatory marker CRP and sed rate. And that helps us determine where we're going to take bone biopsies to treat this patient. If there's a concern of deep tissue infection or joint infections, we'll also get that, because obviously our orthopedic partners are going to need to do something in the joints at the time of surgery. So we often get MRIs for these patients prior to taking them for bone biopsies and definitive drainage and debridement. After you've got them debrided and drained, it's pretty important to proceed fairly quickly to bowel diversion and urinary diversion. Sometimes they already have one or the other, but usually urinary diversion is the reason why I'm there. So your options really from a urinary standpoint is urethral closure and a suprapubic tube if the bladder is appropriate, an ileal conduit, and we'll talk about the trials and tribulations of that later, or possibly in well-selected patients, a bladder neck closure, augmentation, and Mitrophanoff. And in the colorectal options, which actually sometimes I'm just doing both of these if it's just easier for scheduling and stuff. Fecal management system, if it's a temporary situation, it's never good for long term. But ultimately, an ileostomy or colostomy, and increasingly I push towards end colostomies for many of these patients because a lot of reasons why they're there is that their bowels are end stage. This is a classic wound that you can see here. You can see the urethra has been bisected here from pressure injury. So you see the mid-bulbar urethra here is proximal bulbar urethra there. You can even sort of see it going into prosthetic apex. So we mobilize this urethra and end up closing that off at the prosthetic apex, and then just swing a gracilis in. And you can cover it with skin or not. Oftentimes we don't. We just like put a back on it and let it go. So I would be remiss to not include a discussion about malignancy complications with Dr. Carroll in the room. But I will say that it is catastrophic when one of these patients gets a malignancy, but it's very rare. And I'm not totally convinced that these patients get malignancy at higher rates than unaffected individuals, because we don't have great data on it. This is a patient who was older, who had brachytherapy for prostate cancer, obviously, and then came to me with a membranous urethral stricture associated with that brachytherapy. And I was planning on doing an augmentation cystoplasty and a channel on him. And on the day of surgery, severe acute abdominal pain. So I canceled his surgery and got the CT scan. And what you see here, and I had scoped him actually prior to surgery. Now, he had Foley catheter and there's a lot of bolus changes and stuff, but you can see here clearly there's a mass which was high grade. This was in August and he died on Thanksgiving Day. So these tumors tend to be rapidly lethal. We don't really know what the incidence is. Of course, Dr. Huesman has written extensively on this and the folks at Indiana, but it's probably somewhere in the 2 to 3% range lifetime risk. And it's not totally clear if the presence of bowel in the bladder increases the chance of malignancy or not. We know the condition of neurogenic bladder probably increases the risk somewhat, and it definitely increases the lethality of what is already a fairly lethal condition. The risk factors that we think we understand are smoking, of course, we know that's a risk factor for all bladder cancer, immunocompromised status with a history of BK virus, and probably bladder exstrophy increases the risk of cancer. And the published rates of lethality in these is 30 to 50%. But in fact, I've never seen a long-term survivor of any of the cancers that I've seen, which is just a small handful in my career. This is from a review article from Doug Huesman. This is looking at killing colon and ileum augments. And what you see here is the latency is somewhere probably in the 20 to 40 year range from diversion or from augmentation. And they're mostly transitional cells and probably in the extrophy population down here, a little bit more likely to be adenocarcinomas. Now, the problem is sometimes these things are so dedifferentiated, you get something that's sort of like squamous, like horrible dedifferentiated. You don't know if that's a primary TCC with dedifferentiation into squamous or if it was a primary squamous. Gastrocystoplasty, we'll talk about that here in a little bit when we talk about metabolic complications, came into real popularity in the 1990s because of the potential to offset some of the metabolic challenges associated with augmentation cystoplasty. And but we soon found out that gastrocystoplasty substantially increased the risk and decreased the latency time toward cancer to just about 10 to 15 years. And so this practice has really been abandoned in America. These are the screening guidelines I use for bladder cancer screening. I'm not going to go through them, but basically, I get a UA, do an H&P, do further imaging for a patient with cross-sectional imaging or a cysto for anybody that has a filling defect seen on ultrasound or has significant microhematuria or gross hematuria or bladder pain. We don't really know about the risk of other cancers. I've had 4 of my patients die in their 30s and 40s from colorectal cancer, and it would make sense that these patients would be at an increased risk of colorectal cancer, but we're seeing increasing rates of colorectal cancer in young people who are unaffected by spina bifida, but it makes sense if there's something in our diet that's exposing our endothelium to neoplastic changes, that in a patient who has much slower transit is going to get a higher exposure to those. And so I think this is an area where there's opportunity to understand risks for those patients a little bit better. And I have seen a couple of patients with leukemias and lymphomas, again, which could just be baseline. I don't know what the denominator is, but I do wonder about all the radiation these patients are exposed to and what their secondary cancer risk may be from that. I want to talk about metabolic changes, which is now the time that all the residents fall asleep. So try not to fall asleep because there's some pearls in here that are going to get you through a couple points on the in-service. And it's not like people are like, well, how could metabolic changes cause catastrophic end to these patients? But I'm going to try to make that argument to you. I love this picture. I put it in almost every presentation I have because it just absolutely tells you what happens to these patients. So you see this lady, she's got 2 giant stones in her bladder, maybe some little tinkers here. And then she's got a big stag up in her solitary kidney. She's got this horrible scoliosis. This is her spine coming into a sagittal cut. She's got horrible osteopenia seen in her pelvic girdle and femur. And then if we saw any of her lungs, she's got these like tiny little lumps, okay? And this is sort of classic for a patient that's going to have metabolic challenges because they really have the triple whammy. So they often have severe and progressive baseline pulmonary problems. They have atelectasis. They have their neurologic defect impairs them from expanding their thoracic cavity to exchange air well. So they're often at baseline, have a respiratory acidosis. And then if they have a continent urinary reservoir, augmentation cystoplasty, as in that last picture, they're going to be reabsorbing hydrogen ions, right? The bowel, its job is to reabsorb nutrients. The kidneys, its job is to get rid of bad stuff that the body doesn't want. So the kidneys are dumping hydrogen ions into this augmentation cystoplasty that's not being drained reliably. And then the bowel just reabsorbs it and puts it back into the system. So in someone who doesn't have both of those things, you're going to compensate on the other side. You've got a respiratory acidosis, you get a compensatory metabolic alkalosis, or vice versa. These patients can't do that, and they can get profoundly acidotic. And then oftentimes they get progressive renal insufficiency, which then impairs their kidneys from dumping hydrogen ions and all the other garbage like chloride and whatever. And so these patients are a very, very delicate physiologic balance, which is a challenge around surgery in particular, but even at baseline for things like osteoporosis, right? If you're that acidotic, your bones are just going to leach, and other factors. This is the slide you guys should memorize. I'm not going to torture everybody else in the room to talk about this too much, because when we talk about, if you augment with gas with the stomach, you're going to have a metabolic alkalosis. It's typically hypokalemic and chloremic. But most of our patients are augmented either with colon or more commonly ileum, and that results in an acidosis, which is typically hyperchloremic, particularly if colon is used. And just a reminder that B12 is absorbed in the stomach, and everybody says it's resorbed in the terminal ileum, but we know that if a patient has had any aspect of ileal resection, probably jejunal also, they're going to be at risk for B12 deficiency. So the things that drive metabolic risk is the type of segment that's been used in their urinary tract and the amount of urine dwell time. So an incontinent reservoir is going to be less at risk than an incontinent one, particularly in a patient who is maybe not that reliable with their catheterizing, maybe has a massive pouch that's just grown through the years. So the key is to treat base deficit early and consistency. Remenstein at Mannheim University has written a lot on this. He's sort of the heir to the Mainz pouch group, and really advocates for treating base deficit as soon as you divert these patients. And this is sort of an example. This is a really boring slide, but he is a patient that's very close to me. So I started this when I started residency. Okay, I started this graphic. He was a patient who was seen by almost like multiple people in my department through the years for kidney stones. You can see he's had all of these insults to his kidneys. This is creatinine, so 4 and 2 and 1. So his creatinine was 1 at the beginning of my residency, and then he had all these insults: bladder stone and a kidney stone and a right kidney stone, and then he's had wound problems, had a chronic Foley placed, and then it started requiring cystoscopic Foley exchange. He was 400 pounds. Ultimately had a suprapubic tube, which I placed and hoped that would get him out of harm's way. But then it became a lot of leakage around his suprapubic tube because his bladder was so small, and ultimately underwent cystectomy and ileoconduit by me, which took him down fairly well, but he was lost to follow-up and had progressive medical disease that was untreated, and ultimately showed back up in my clinic with end-stage renal disease. And so that, I think that's like a story, right? I mean, this is catastrophic, right? This is a guy who's had multiple intersections with our department and with the healthcare world. His father's actually a social worker, and yet he still ended up with end-stage renal disease. These patients can get pathologic fractures from their osteopenia that's unmanaged. So prevention is really the answer, and to the extent you can. I mean, you can't make patients who don't want to come back and see you come back and see you, but to the extent that you can get them back into the clinic and manage these things. So correct their base excess with usually potassium citrate. Sometimes you have to do something else, and I'll let Dr. Stoller advise on that. A kidney surveillance and protection is really important. So every patient every year in my practice, and I suspect here too, gets a renal bladder ultrasound, a UA, a BMP, and blood pressure annually. Now, a BMP, so what's the most important thing in a BMP? Somebody tell me. Adrian.
Creatinine?
Wrong. So if for every other patient, creatinine is the most important thing. These patients, you got to look at their potassium, their chloride, and their bicarb. Okay, the creatinine is a fake out. These patients really need to have non-creatinine-based estimates of GFR because they're in chairs and they don't generate muscle waste. Treat retention. So if these patients have a hernia, their conduit's not draining, or they have massive pouches, they're going to resorb all those hydrogen ions. And treat their pulmonary disease. You don't have to treat their pulmonary disease. You just have to make sure you get a safe study on them and refer them to pulmonology, because these patients all have pulmonary disease and they will be benefited from getting plugged in with a pulmonologist. Many of them, their primary care doctors are nurse practitioners that have no understanding of this complex physiology. And so the one doctor that sees them every year that's going to understand this best is the urologist. And here's my argument for cystatin. So I get no proceeds from cystatin testing. I do not have a conflict of interest with cystatin, but we have looked at cystatin. So we took patients who were non-weight bearing and patients who were weight bearing, case controlled, and matched for all other kidney risk factors, including presence of proteinuria, hypertension, et cetera. And we calculated, for which we had a creatinine and a cystatin within a couple week period. And we calculated their eGFRs based on the creatinine-based CKD epi equation, the creatinine plus cystatin, and then just the cystatin alone. And what you can see here, I'm sort of losing my thing, but what you can see here in the non-weight bearing, you see that the eGFR calculation in the patients based on creatinine alone was 106.8 on average. But by cystatin, by creatinine alone, by cystatin, it was about 80. Almost all patients who meet this definition are going to be substantially upstaged to a higher level of renal insufficiency if you use cystatin. And so if you're just getting creatinine, you're not really understanding what their true renal function is. And this is a good example. This is a patient, and the images are sort of not that great because he has all this fine hardware, but you just have to trust me. He's got this little peanut of a kidney that's sort of lobulated from prior scarring. We got, both of these things, and his eGFR or his creatinine was 0.5. So you're like, okay, we're fine. The guy's fine, right? No, he's not. His cystatin was 1.43, which created these two different estimates of GFR. So that would put him, the top one, this creatinine-based one, will put him as a no renal failure. And then, a GFR of 55 is going to put him in the type 2, 2B, right? Just a word on this. This is getting super deep and super dark and boring, so I'm not going to belabor this. But I'm going to ask the residents, if you are interested in this topic and want to do a little deeper dive, to go get this review article that's in the New England Journal. It's great. I have copies of it in my office. I give it to a lot of people. It just is a very thorough review of B12 deficiency. I think of B12 deficiency as it's like the syphilis of metabolic problems, because it shows up in every system and it's really hard to identify. And especially in patients who already have a baseline neurologic defect, right? Because you see all these, you see over here in this, my thing keeps going away, but you see it's like dorsal column things, they've got ataxia, paresthesia, is like all these things that these patients already have. And so they come in and they're like, yeah, I have a little more spasticity in my leg. You're like, okay, do they need to go see the neurosurgeon? Do they need to be retethered or untethered? Or is this B12 deficiency? And so it's your job to make sure that that's not it, because it's really treatable. And the other thing is it causes anemias. And almost all of these patients have some anemia in adulthood. And so you got to make sure particularly if they got megaloblastic anemia, I spelled that wrong, that you're measuring and treating. So I just measure and treat all. And I used to be more selective about it. And then I went to see my doctor and I got a B12. And I, as far as I know, don't have short gut and haven't had an augmentation cystoplasty, and my B12 levels are 300. So I think it's a pretty common thing, but these patients can't afford to lose more function. Okay, and they cannot afford to be anemic. So measure and treat. This is again boring, but the takeaway is the patients having acute symptoms. I refer them to hematology to get IM or IV infusions of B12. Otherwise, you can treat these patients parenterally, even if they've had bowel resected and had their terminal ileum resected. So you put them on high dose, 2,000 micrograms of B12 a day, and then you just recheck a BMP and a B12 in 3 months and annually thereafter. I'm going to just turn this last part of this conversation to hernias. I talked about this a lot at our GERS meeting last week, so I won't belabor it too much. But this is something I've been working on a lot in my current career, and mainly because I've developed a really positive relationship with our abdominal wall team. And so it's been fun to sort of learn about how we can do better with this. This first patient is a patient that was admitted with this finding. Most of her small bowel and portion of her colon was incarcerated in her peristomal hernia, and she had a massive bowel resection and ultimately ended up dying on this hospitalization. Also, patients come in like this, they can't fit a bag, they're just wearing towels over that, they're getting tons of ulcerations, et cetera, et cetera. Or they can have obstruction of their stoma from the herniation, and then that causes secondary hydronephrosis and renal deterioration. And they come in all different forms. It can be tricky to figure out in a patient that has hydronephrosis, like, is it because the hernia is obstructing? Is it because it's hernia plus or minus 1 or 2 ureteroenteric anastomotic strictures? You can see here, here's an augmentation that's herniated into a ventral defect, or you can have just like all the viscera coming out. The moral, and most of these patients have complex hernias. So this is, you can see it has a component of a ventral hernia as well as a peristomal. And this makes it really difficult, particularly in these patients that are in chairs, to fit their bags. And so oftentimes you are the first person to see them because they're getting poor fit of their ostomy bags. They're saying, I need, so many more ostomy bags, or whatever the case may be. These patients need to be evaluated and treated for that, if nothing else. This is a pretty interesting patient that I've recently taken care of. She had OEIS, which is, coequal extrophy syndrome that includes myelo, but also had failed closure of her pelvic girdle at birth. So when she had osteotomies at birth, and then she also actually had cutaneous ureterostomies. And she actually had a hernia, you can see here through Pettit's triangle, that included her ureter. And had some obstruction and recurrent pyelo from that. So that these hernias can be quite unusual. So complex hernias, they're very common and they're poorly reported. If you don't ask about them and ask about the symptoms, particularly bag fit for these patients, you're probably gonna miss a lot of them. Again, it's not something that we are primarily the best at fixing. And so I partner with ab wall specialists in fixing them. And I really just do whatever they tell me to do in terms of relocation of the stoma or revision of it. Our stage approach is sometimes necessary. And I'll show you an example of that, particularly if there's contamination, particularly if the patient has a DP shunt. And sometimes conversion to a continent diversion may be relevant. Now, that has to be a patient who's going to take care of a continent diversion, but a small hole through a reconstructed abdomen with a channel is much less likely to recur than a replaced peristomal, replaced conduit. And so sometimes we think about that. And of course, team approach is optimal. This is our experience with paras. I am proud and also embarrassed to say that the benign group, there's about 100 patients for which we had 2-year CT scan data. So the malignant ones, like those guys are getting CT surveillance for their cancer. The benign ones, we don't often get CT. So it was just the ones for which we had CT, which is, they show up in an ER with a nosebleed and they get a CT. So, but the rate of peristomal hernias at 2 years was about 30% and higher in the benign group, which most of these patients are spinal cord injured and spina bifida patients. Spina bifida patients are very high risk for recurrence. They tend to be obese, they have weak abdominal walls, and then they transfer, using their abdominal power, and so all those things put them at higher risk. It's important as urologists not to fix the problem, but to make sure that their ureteroenteric anastomoses are okay. If there's anything else that needs to happen, to just fix it while you're in there, because the goal is to never have to go back into this patient's abdomens. And usually, so I won't get into this too much, but usually when the ab wall folks are talking about repairing a peristomal hernia, they use 2 different types, like either a keyhole or a sugar baker. And normally the keyhole is a better one for drainage. And so that is the preference, but always if we use a keyhole, we relocate the stoma. We don't leave it in the same location. And so if you're going to have to relocate the stoma, non-con CT or lupogram, as I'll show you in a second, will give you a good idea of how long that thing is and where the ureters are, to see if you can bring it over to another site. Or maybe you have to do a little add-on, take another piece of small bowel right at your prior anastomotic site and just add it on, so you get a little bit more length on that. Lupogram is my favorite diagnostic procedure because it gives you a lot of information about the condition of the ureteroenteric anastomosis and also the length of the stoma. It also gives you an idea in patients who've already been repaired once or twice before about whether anything else is going on. So this is a patient, you can see the tacks in her abdominal wall. I mean, she's just had a lot of problems and went in for a definitive repair at another institution. They got into the bowel and sort of put this large piece of alloderm or something like that in there, which subsequently has become infected. And at that site there, this is my lupogram. You can sort of see along here that there's some drainage of contrast along the fascia. So the fascia has eroded into the ileal conduit, and she's got just like spouty little fistulas through her skin. So this mesh is all infected. And worse, you can see here, she's got a VP shunt. So we have a patient with an infected mesh in her abdomen, an eroded conduit, a VP shunt. And this is a picture, this is a cross-sectional image of her CT scan. You can see these little tacks here and then these pockets of air and drainage along here. And so that's a really hard thing to think about. You've got to sit down with the neurosurgeon and with your ab wall person and say, how are we going to do this? This has to be done as a staged approach. Get all the garbage out of there, get the patient, temporarily closed, and then go back in for a definitive repair once you get everything cleaned up from an infection standpoint, and thinking about how you're going to manage that VP shunt along the way. So just to summarize, age-related functional decline happens in every human being born on this earth that lives past the age of 18. But it starts earlier and it's much more pronounced in patients with spina bifida. Hopefully in my lifetime, I've actually just taken a position with the CDC to work on these sort of longevity issues 1 day a week so we can understand what their natural history of these patients are, what the kind of morbidities are they're living with in adult life, and what they're dying from and when. Incontinence and age are really the biggest drivers of skin breakdown and probably quality of life in these patients, and you got to manage it early and aggressively. Metabolic challenges are boring, and often people, as urologists, don't think that's something that they should look after, but honestly, we are often the de facto nephrologists for these patients and the first line of management medically for them, and the people that understand their physiology the best. And so getting them to the appropriate people, whether that's bone health specialists or pulmonary specialists or nephrologists, is really important and part of our duty as urologists. The ventral wall problems increase with age, and every time we try to repair these, get more complex to fix. And so partnering with specialists and actually as an organization trying to think about how we can prevent these going forward, I think is a really important thing we need to think about as reconstructive urologists. And all of these problems are much easier to prevent than to fix. They're not easy to prevent, but if you can prevent them, then you may have saved a life. So thank you.
Questions for Dr. Wood?
I mean, a great talk. It's really good to see that you're constructing these data sets to allow us to determine the real natural history of this disease, because I don't think they existed 5 or 7 years ago. You mentioned ventral wall problems with a hernia rate of 28%. What do you do at the time of diversion to try and reduce that? So there's some special techniques that you use at the time of diversion, mesh at the beginning to prevent these from happening since the incidence is so high.
Yeah, so the question from Dr. Carroll is how can we prevent hernias at the time of initial diversion? And I think the jury's out on that. There have been some studies that have looked at preventive placement of mesh at the time of initial diversion. Those studies are mostly looking at, bye Jerry, thanks for coming. Most people have looked at, it's sort of mixed studies, includes ileostomies and colostomies. We're doing one that's NIH funded that's just starting right now. So I think we need to monitor that a little bit better. And actually, I don't have greater ideas. You can't really, these patients, you can't get them to lose weight. I mean, they're in chairs, they're burning like 0 calories a day, and you can't get them to change the way they transfer in and out of their chairs. There's just so many factors that maybe might be modifiable in a patient who's ambulatory, but not in this group. And even if you look at the rates of laparoscopic versus open, we're not seeing big differences. Now, our data was only 100 patients. Maybe that will grow because there was a difference. It was not significant, so then it's not a difference. You know, a lot of these patients, you don't have an option of doing robotic or laparoscopic because they've been multiply X-lapped, and so it's hard to know. But this is a cost of doing these surgeries, and we need to acknowledge that and consent patients when we'll talk to them about that when we're consenting them. And then hopefully the smart people in this room can help us figure that question out in the next 10 or 20 years.
We've had a great talk. I'm just also amazed by your commitment to these patients over time who are so challenging, and thanks for, you know, your advocacy for them in our community. I love your focus on the metabolic acidosis. It's something I talk about and teach about a lot because I think it's a missed opportunity. And I've started actually getting DEXA. I'm pretty aggressive now about getting DEXA scans in these patients, and I'm interested in kind of your approach to them. We had a lot of back and forth and thinking about like, well, what do you actually scan for the DEXA? Because, you know, whereas you might usually look at the pelvis, that is really very atypical in many of these spina bifida patients. And so we've kind of settled on doing forearm DEXAs, but I'm curious, like, what's your, you know, do you use them regularly, and how do you attain them?
Yes, and that's a really interesting question, and one that I haven't thought about because the pelvic girdles are always really osteopenic in these patients, but it's standard to do the wrist at our institution. But we do get, and this is mostly done by the med peds guy that's in my clinic. But we get DEXAs and we get sleep studies on all of these patients, basically, if they haven't already had them, and then we get them treated for their. And these are young people, right? They're 20, so it's not indicated to get a DEXA in a woman, so she's, you know, perimenopausal or whatever. But we're getting these really young, and we're treating them as aggressively as we can.
Ben? Can you describe for us how you set up your clinic, and what are the sort of collaborative aspects to it?
Okay, the question is how I set up my clinic. So I have a multidisciplinary adult spina bifida clinic, and I would say that probably less than 10% of my spina bifida patients are in that clinic. Most of my patients that I see just in my regular recon clinic, which is challenging because these patients require lift teams to get out of their chair. So it's sort of resource intensive and time intensive to see them, but there's no other way to do that. So we have a clinic 1 day per month. And normally what we do is we have a med peds person. We have our head of spinal cord injury, he's an expert in spinal cord injury. He takes care of all these patients. He's a physiatrist. And then we have our nurse practitioner who runs the NSBPR data collection. And we have a neurosurgeon who comes in as needed. So he's in the OR, and I'll just say, Cheryl, we've got 2 patients you need to see today that have MRIs with them, and he sees them. So we pre-screen these patients, we decide what they need, we order that stuff up. Usually they're getting them after the clinic. So it's sort of a nightmare because they're like going off and getting their ultrasound, and then you got to close the loop on it. But practically that was the only way we could do it. We get labs on them, and the med peds guys doing most of the metabolic stuff now. And then we have a Zoom meeting after that clinic where we run all the patients, and we have a social worker that participates in that. She can't be in the clinic. She's not, it's like a side gig for her. She doesn't get paid for it. It's just like her lunch time. And so, but if we need her to help one of our patients, she's willing to help. And then I have a couple of people sort of on call. So when Christy, the plastic surgeon, was with us, she would come and see patients in clinic. She was in the operating room that day, so she'd come up and see patients that needed to be seen. And then I have a gynae who has a research block in the afternoon. So if a patient needs to go over and see gynae, I'll package them up and send them over to gynecology, and she'll see them as an add-on. So it's hard because it's really hard in the adult world to justify taking all these specialists and having only see a couple patients a day. And so we're trying to be efficient with that. We have one person who's off-site that day that we can put the patient in a Zoom room if they need a special appointment for that. It's a nutritionist, and we just put them in the Zoom room, and then we just plug them in that way after they've seen all the providers in the clinic. So it's chaotic, and it's really hard to get patients moving through and stuff, but but it's pretty high yield for them. They get to see a lot of doctors in one day. And so those tend to be like patients that are flying in from outside that want like just a once over of a bunch of stuff. We make a plan and then we have them come back as needed for either surgery or we connect with them virtually thereafter.
Marshall, any questions?
I see a lot of these patients with stone disease, and it could be very frustrating in terms of just getting access to their kidney with a variety of diversions or the like. Do you put them on any prophylactic approaches to try to prevent stone disease?
So, I mean, beyond sort of like Urosit, in patients that have pretty big, have base deficit or have some risk factor for that, if it gets complicated, which it does in a lot of these, as you know, Marshall, because they have short gut, they've got chronic acidosis, and then they've got osteomalacia. I plug them in with our metabolic stone clinic because that's like above my, pay grade. So it's too complicated for me. So then I let the experts take over from there.
Because for me, it's very frustrating in that you deal with the stone and then 3 or 4 years later, they come back with another huge stone, and just getting access, because retrograde approaches are really almost impossible on some of these people. You've got to do it percutaneously. And I feel like that is a big part of their renal insufficiency, like you were talking about before, not just the osteopenia and acidosis, but the hit that they have from obstructive uropathy from the stones.
So let me turn it back on you. What do you do? So I get a lot of all these patients have stones in their kidneys, right? Small stones.
Right.
I usually don't even involve our endo team until the stone is like 9 or 10 millimeters, because they're always going to have stones. Like you can take care of that, and then a year later they got another stone, and there's a chance they can pass them until they're 8-9 millimeters. And I tell them, if you have flank pain, abdominal pain, fevers of unexplained, like the stone could be dropping down. But until they're sort of at the sort of far end of ureteroscopic management, then I usually send them over. Do you want to manage this ureteroscopically before it gets, before the horse is out of the barn? What's your recommendation?
Well, no, I think they need a full metabolic evaluation. And I think the acidosis is the biggest issue. It's sort of like someone who's on bed rest who has a broken tib-fib fracture. The incidence of their stones goes very high. So there's just no mobility. And I think the bone loss is a big deal where they get hypercalciuria. And I think, the 5 types of hypercalciuria, you need to evaluate them. And as you said in your lecture, whether you put them on hydrochlorothiazide, hydrochlorothalidone, or something to cause reabsorption of their calcium, can be very helpful in these individuals. So I think it's a challenge. And unfortunately, in the stone world, it's not a static problem, just like in your situation. It's not a static problem. It evolves with time. But I do think that it is worthwhile to have follow-up. And that's why the stone clinics get so bogged down, because you see these people and it's not like one done and you're over. It's a matter of when they're going to recur.
This is a great idea for a quality project with you and Lindsay and a very brave resident to work on this here.
Right. Great talk. We really enjoyed it.
Thank you, Marshall.
When did you get back from
Thanks, Marshall.
Okay, thanks. Thanks, Ken.
We had our clinic yesterday. We were talking about
you got
stones for informal lady
I should work on it.
like, what do you do about 20, even like the, metabolic, 24-hour metabolic evaluation?
Oh.
I don't even know how to
It's really
that
hard.
many
Yeah.
people that have like augments.
And
It's really hard to collect you.
How's it going?
Okay.
You got your coffee? I think that's good.
But
Okay, sorry.
We got a little break here.
Amy, watching you work this weekend, sorry, today with your little remote access pad and your terrible paging system. questions answered or?
I actually can't share. Not, but whenever I'm interested system innovation, looking at the California
Like,
statewide
solid,
because, okay, all right.
5 weeks